Hello everyone, welcome back to Exam Key Point Dentistry. Today we are going to discuss bilateral sagittal split osteotomy, that is the BSSO. So BSSO is one of the most commonly performed orthodontic surgeries of the mandible. It is a very versatile procedure. It can be used in many mandibular deformities. This procedure was first described by obwegeser and Trainer and later modified by the Dahl-Pont. In this surgery, we split the mandibular ramus and the posterior body of the mandible in a sagittal direction. Because of this split, we can move the mandible forward and the backward, that is a setback or advancement. So the diagram shows the mandible divided into two segments, that is a tooth bearing segments and the condylar bearing segments, and the arrows show the forward and the backward movement. So here it will show forward and the backward movement. Okay, now the surgical procedure. So first one is incision and dissection. Now let us understand step by step. So the incision start at the interior aspect of the ramus. It is placed between the upper and the lower molar region. So you see this point here, it is start between the upper and the lower molar region. The length of the incision is about 2 cm long. It runs downward along the external oblique ridge and end in the facial vestibule near the first molar region. So it will be run downward along the external oblique ridge and it will be end in the facial vestibule near the first molar. So you see this is the first molar, so it will be end here somewhere like this. Okay, so after that we do sharp dissection of the mucosa. The buccinator muscle is dissected mesially and we try to keep the maximum soft tissue laterally. Okay, so the incision goes through mucosa periosteum up to the bone. So here the important point is full thickness mucoperiosteal flap is reflected. Okay, now the second step is osteotomic cut. This is the most important step. We make 3 corticotomy cuts. So the first cut is lingual cut. Okay, so this cut is made on the lingual cortex just above the mandibular foramen and it is parallel to the occlusal plane. Okay, so here you see this is the mandibular foramen where it is the entrance of the inferior alveolar canal. Okay, so it is extend from the anterior border of the ramus. So this one is anterior border, so it will extend from here anterior border of the ramus just behind the lingula. Okay, where the entrance of the inferior alveolar canal. So here it is entry of the inferior alveolar canal, so just behind the lingual cortex we will extending. Okay, so the red line show the lingual cut above the mandibular foramen. Now the second cut is, okay, so this one is first cut. Now the second corticotomy is made on the buccal cortex in a vertical direction at the level of the first or the second molar. So here it is at the level of the first vertical direction. In a vertical direction a second corticotomy is cut. Okay, so the cut extend downward up to the inferior border of the mandible and curve through it. So this one is second. So the vertical red line seen in molar region extending to the lower border is the second cut. Now the third cut is connecting the first lingual cut and the second lingual cut. So it will be run along the anterior border of the ramus like this. So this one is third. Okay, this one is first, this one is second and this one is third. So third one connecting the first lingual cut and the second. Now all 3 cuts are connecting. Okay, now the next step is sagittal split. So using a thin osteotomy, a ramus is split from the anterior border and the posterior border of the ramus. So now the mandible is divided into tooth bearing segments and the condylar bearing segment. Okay, so fourth one is mobilization. So a special bone spreader can be used to mobilize these segments. To separate the 2 segments we use bone spreader. Okay, so after the bilateral split the tooth bearing segments can be moved in 3-dimensionally. Okay, you see a tooth and move 3-dimensionally, that is a forward like this. In forward we move here, backward like this, and the sideways like this. Okay, sideways we move. So the diagram show the movement arrow in different direction. Okay, Now the positioning of the tooth bearing segment. So after the osteotomy, on the both the side, a prefabricating interocclusal acrylic viva split is placed. Maxillomandibular fixation is achieved using a 3-wire ligature. So here in this case, the important is teeth must be in proper 3-point contact, so that there is no shifting occurs during the fixation. Okay. So positioning, now the next one is positioning of the condylar bearing segment. So it is a very important step. So we must maintain the normal condylar position and the proper glenoid fossa relation, and it is usually done by the manually positioning, and condylar is pushed superiorly into the glenoid fossa. So this will prevent the condylar displacement. Okay. Now the next step is fixation technique. So here the different fixation method is with wire fixation at the upper and the lower border, lag screw, that is a bicortical screw, mini plate, and bioresorbable plates and the screw. So you see how it will done the fixation. Now the complication. So here it is important viva question. So complication is injury to the inferior alveolar nerve, injury to the lingual nerve. There is a displacement of the condyle, hemorrhage, but it is a rare condition, infection, and the relapse. So most common complication is temporary or permanent inferior alveolar nerve paresthesia. So students, today we understood definition, history, surgical step, osteotomic cut, positioning, fixation, and complication. So BSSO is a very important orthodontic surgery for the mandibular prognathism, retrognathism, and facial deformities. So if you found this video helpful, like, share, and subscribe to my channel, Exam Key Point Dentistry. Thank you so much. See you in the next video.